And we have there a question: is normal sinus rhythm present in the ECG shown below? Okay. All right, so sinus rhythm, we look at regularity, and we look at a rate of, so can someone type for me what the rate is for sinus rhythm? Normal sinus rhythm, what's the rate? Thanks, Bernadette. Yeah, 60 to 100. Lovely. That's easy, isn't it? We know that. And it has to be regular. So what do you think? Do you think we've got sinus rhythm there in those ECGs? Or ECG printout? Bindu says yes. Anyone else agree? Okay. So, I mean, in fact, in AVR, we've got a back the front P wave there. Is that normal? An upside down P wave in AVR? Yes, it is normal, isn't it? So, but in lead 2, we've got an upright P wave, which is what we want in a sinus rhythm. Yeah, very good. All right, so yes, we do have sinus rhythm in that particular rhythm strip. All right, so what about this one here? This is a little 6-second strip, and the question is normal sinus rhythm present in this rhythm strip? So have a very careful look at that. Thanks. I can't, I'm struggling with your name, Cavathemol. Thank you. Yes, we've got an inverted P wave there. And is that an issue in lead 2? Is that normal in lead 2? No, it's not. And in fact, what happens is that anything that is upside down means that the direction of that conducting system, instead of going that way, it actually goes backwards a little bit, doesn't it? Yeah. So it's probably commencing at the AV node and going backwards rather than being anywhere near the SA node. So what type of rhythm might this be? Kerry, you nearly had it. Yeah, junctional-ish. We'd need to look far more at than just this little strip, but it's suggestive of that, isn't it? Yeah. All right, lovely. All right, so let's have a look. We've got a rhythm strip here. We've got a 6-second strip. It's in V1, which is interesting. And the question is based on the rhythm strip shown below. Why might this patient complain of an occasional palpitation? Let's have a look. We've got some interesting features there, haven't we? Yeah. Yeah, so atrial ectopic beat, I think Cavathemol's saying. Is that right? Yep. So we do have one of those here somewhere. Yep. So they're early, a little bit early, and they're going. Yeah. So that in fact, that one there you would get a palpitation from that. Yep. Good. Okay. Well, next, if we go down to, pardon me, the next one, it says, what is the beat marked X? Okay, and we find that it's an interesting beat because there's not too many P waves available there, are there? What do you think that is? If there's no P wave, which is, of course is the sinoatrial node, what have you got? Well, it could be a ventricular one. However, do you know, the interesting thing about ventricular ones is the ventricular ones are actually just a bit wider, aren't they? If you had a look, they would probably be like that rather than thinner like that. So, and that's a secret to knowing whether something's ventricular. Yeah, well, there must be a little bit of a block there somewhere, mustn't there? Because it's not coming from the SA node. But because there's no P wave, it is junctional. That's right, Bindu. Beautiful. So that's actually an ectopic beat from the junctional area, all right? But this one isn't because it's got a lovely P wave there. I'll just get rid of that. You can probably see, and if you've got a little ruler onto that, that this one here is actually closer together than this one, okay? All right, so the further down the block or the origin, the wider the QRS complex. All right, that's important to note. It's got a lot to do with the fact that in the conducting system that the cells are slower and slower as they go down. It's very fast in the SA node, gets to the AV, slows down a bit, and then when it goes down the ventricular system, it is faster, but it's not as fast as it is up in the SA node, and so that's why you get the wider complexes, all right? Because what these are, these ECG printouts are just electrical conduction graphs, really, aren't they? All right, so let's have a look at the rhythm strip below. This is a 6-second strip and it's in lead 2. All right, so if we count them up and we multiply them by 10, what do we get for a heart rate? An approximate heart rate. Okay. All right, just saying this is the 6-second strip. Okay, then we multiply it by 10, so it's more in the 200s, isn't it, than it is in the hundreds. So I probably didn't explain that too well, but it's closer to the 210 than it is to 110. All right, so makes it a little bit tricky, doesn't it, when I don't explain it like that. However, when you see something on the monitor like that, I want you to be able to get used to seeing what rhythm looks like, you know, and if it's close and if it isn't, and what a normal heart rate. So you don't have to continually look at the rate on the monitor. You can quickly scan the monitor and go, wow, that's fast. Okay. So anyway, it is a tachyarrhythmia, isn't it? Suganthi, you've got a question? Yeah? Okay. If you do, just keep typing. Just ignore me. I'll see your question. What type of tachyarrhythmia is present? And we've got a choice of sinus tachy, paroxysmal supraventricular tachycardia, atrial flutter, atrial fibrillation, and multifocal atrial tachycardia. So which of those 5 do you think it is? Yeah, number 2, cavithamol. Anyone else? You can agree, you can disagree. I just want to get a consensus. I just don't want to go with the first answer. I want you all to have a chance to answer. Yeah, yep. Sinus tachy is another, yep. Okay, so let's have a look at this. Okay, Sophie, you've raised your hand. All right, let's look at this. All right, so sinus tachycardia. What's the range of sinus tachycardia? Do you remember? Yes, it's about 100 to 150. And if this is 210, then even though it looks like a sinus tachycardia, it's actually too fast for a sinus tachy. All right. And you can see that it probably is a supraventricular tachycardia, which means that it's above the normal tachycardia range, which it is. It's 210, and 150 is about the limit you get to. So paroxysmal means that it's probably retrograde, and a retrograde P wave may be seen just after the QRS, making the AV ventricular nodal re-entry tachycardia the most likely mechanism for this arrhythmia. So if you have a look very carefully, in some of them you can see a little P wave just on the odd, tiny, isn't it? Tiny, tiny little thing there. So if you're having a look at that, and that's the thing you should look for, and you've really got to do the ECG to do this, is that that's what makes it a re-entry tachycardia, okay? And that is a paroxysmal supraventricular tachycardia. Flutter, it could be flutter because it's even, but and then again, you don't tend to get flutter as quickly as that. Atrial fibrillation wouldn't be regular. See how these are regular? Okay. So that's important to know. Atrial fibrillation is always irregular. And multifocal atrial tachycardia, you would have the P waves all over the place. You wouldn't have them nice and even. So it's not that. All right. Okay. So true or false? Paroxysmal supraventricular tachycardia, keep typing, Saganthi, represents sinus tachy at a very rapid rate at rest. Is that true or false? We've got a true there. Jane says a true. All right. Now this is a tricky one because, yeah. Now, Kavithamal, you've actually raised your hand, but you can just keep typing. I think you might have done that by accident. Yeah. Yeah. All right. Linda, what do you think? There's a big bump. Yeah. big bump. I'll just after the little P wave, and then yeah. Okay, so yeah, that's a good question. Sophie says 2. False. Is that what you mean? True. Okay. All right, so let's have a look at this. Yeah, Bindu's not sure, are you now? You're starting to question it. So if we had sinus, remember it's sinus we're asking, we would have a normal P wave. Now this P wave does happen and it does follow with a QRS, but we find that we've got little buried P waves here, haven't we? So in fact what's happening, and I'll just quickly draw a sort of a heart thing here for you, excuse the dreadful drawing, and these are your atrial here. Normally from the SA node here we would get direction, but what's happening is that it's a re-entry. So we've got this cycle of stimulation happening in there before it gets to the AV node there. Okay, so in fact it's not originating up here. Sorry, that's a bit big. Up here, it's originating somewhere within the atria. So it isn't actually truly sinus, even though we could debate that. You know what I mean? So, in fact, the sinus part does diminish when we get a heart rate that is above, above 150 or 100, all right? So it becomes then supraventricular. So, in fact, the answer to this is false, all right? Very, very tricky question, all right, for those guys who on first face value felt it might have been sinus, but in fact it isn't, because of just simple definitions, okay? Yeah, the treatment is different. If it was sinus, we wouldn't be doing very much about it, apart from trying to slow it down maybe, because anything above 150 gets to be a little bit dangerous. All right, let's move on. Okay, now let's have a look. We've got a 6-second strip here. And the question is, what is the atrial rate? So it doesn't say what lead it is in, but we seem to have a lot of P waves there. And they seem to be upside down. So the atrial rate, we need to count those P waves. And I've got about 300 beats per minute. So there's some buried as well. So I won't ask you that one. So that's about 300. What is the ventricular rate? Well, you can count those quite easily. So what is the ventricular rate? Who can count those for me? Yes, about 80. Beautiful. All right, so what have we got there in this rhythm? What's happening in this rhythm? What is the arrhythmia? It's not sinus, is it? Good. Yep. Yes, it does look like a flutter, and the definitions of flutter is that it's nice and even. It looks like sawtooth sort of look. Yeah, it is a flutter, and in fact it's atrial flutter, and you can see we get about 4 little waves to about 1. It's 4 to 1, and every 4th we actually get conduction, okay, and we get conduction down to the ventricles. All right, so that's what that is. If we cross that one off and that one off, we'd have 3 to 1. All right, we've got one buried. That's what makes it very tricky. All right, let's move down. We've got lead 2 here. All right, we've got a 6-second strip. And when I say the average heart rate here, it's because it's a particular rhythm, we've got to ask what the average heart rate is. So I might give it away about the arrhythmia. But what do you get for an average heart rate if this is a 6-second strip and we multiply the ventricular contractions by 10? Yep, we got about 80 there, 90, yes, give or take a bit. Yep, so it's within that sinus range, isn't it? But it's not a sinus because it's irregular. So what is the arrhythmia? Yeah, it's atrial fib, isn't it? And we've got to be careful distinguishing that to ventricular fibrillation, yeah. And you can see all the fibrillating P waves here. It's quite a lot of them, okay? They're very irregular. And we're getting irregular conduction, whereas in flutter we get regular conduction. In atrial fibrillation we get irregular conduction and we get fibrillation waves. This is the most common rhythm that you will see in the ICU is AF, okay? And you probably know that. All right, so the next question is the atrial rate with atrial flutter. Is it faster or slower than the atrial rate with atrial fibrillation? Yeah, consensus seems to be that it's slower. Jane? No, I can't count fib. It's a good question. Yeah, so yeah, the answer is slower. Okay, because we really can't count the fibrillation rate. Now, Bindu, do you get that? Do you understand that? Okay. Yeah, okay, good. All right, the next one is the atrial rate with atrial flutter is usually faster or slower than that with atrial tachycardia. Now that's a tricky one. What do you think? We've got one answer. Any more? You're not sure, are you? Okay, the answer is ta-da, faster. So generally with atrial tachycardia, what we do is we get conduction with every P wave, whereas with flutter, we get conduction with every third or fourth. Flutter is generally faster because of that reason, okay? Not that that is something that will make any difference in your practice, but it's just one of those interesting facts. We don't see a lot of atrial flutter compared to atrial tachycardia in the same patient. All right, true or false? The ventricular rate with atrial fibrillation is always greater than 100 beats per minute. True or false? That's right, you can have quite slow atrial fibrillation, can't you? Alice, good. Keep typing, Alice. Can be, yes. All right, lovely. Next one, true or false? Systemic embolization causing stroke or vascular occlusion is not a risk with atrial flutter. Okay. And that, of course, is false, isn't it? People who've got long-term atrial flutter, as they do with atrial fibrillation, probably need something to fix the clotting of blood in the atrium, don't they? So they don't get a stroke. Yep. Yep. So that's right. That's a false. Okay, moving on. We have lead 2 there. It's an arrhythmia. And we have a very wide complex. You should be able to recognise this arrhythmia. What do you think it is? Oh, it's lovely to see the quick response and so correct. That's great. Yes, it's ventricular tachycardia, and it's monomorphic because there's one type of morphology to the type of complex there. Yeah, you can see it originates in the ventricles. It's actually really wide compared to, and you can see this complex up here, which is above the ventricles, and that's not quite as wide. And that's a giveaway, isn't it? Okay, so we've got another arrhythmia there, which is wide, so it's obviously a ventricular strip. But this one's a little bit different. So what do you think this arrhythmia is? Got torsades, yes. Torsades, yep. Alice, yeah, totally agree, yes. And of course we can see it spinning on itself there. It gets small there, large again, small. And this, of course, is where you often give a bit of magnesium, don't you, for these patients because the magnesium's got quite low. All right. Now, the next one is name 3 potentially treatable causes of ventricular premature beats. And of course, you tend to see that in patients who are potassium issues, yeah. Hypokalemia, hypomagnesia, yep. Beautiful. Yep. If the patient, yeah, calcium, yep, calcium not quite as much, but probably if it was, and of course we look at ionised calcium nowadays more so than the serum calcium, but the ionised calcium's low, then you tend to get that, yeah. And also hypoxemia, yes, beautiful. And something you probably don't think about if there's digitoxicity. We don't seem to see that as much nowadays, but digitoxicity is something which will give you premature beats. All right, let's look down there. Lead 2, we've got some strange looking complexes there. And what's the arrhythmia? Yep, we've got PVCs. Yep, premature ventricular contractions, and in fact we've got them every second beat, so it becomes by Gemini. Lovely. Good. All right. Okay. Now, so the rhythm strip below shows sinus rhythm with which of the following, and you've got a choice. We've got a winky back type, second degree AV block, complete heart block, 3-to-1 AV block, AV dissociation, or blocked premature atrial beats. This is in lead V1. Okay. Have a look at that closely. In fact, what we find there is there must be a P wave there. But it's getting longer and longer, isn't it? And then suddenly we seem to get 2 P waves and we've dropped a complex there, haven't we? Yeah. In fact, if you listen to this on the monitor, you could hear that beat getting longer and longer and then a drop beat. Yeah. Yeah, and if we drop a beat, that's very typical of number A, which is a winky back, a second degree AV block. All right, you can see it's happening regularly. There, we're dropping that beat. If we had complete heart block, we'd have complete dissociation between the P waves and the QRSs. And in fact, we don't have that in every complex. We only have it where it's dropped. 3 to 1 AV block, there's 4 complexes there, and there's 3 there, and there's 2, which is also particularly found in winky back. AV dissociation, well, there is that, but it's not to the same degree of AV dissociations are a very broad term. And blocked premature atrial beats, that again is a broad term and not specific. So, in fact, the answer is winky back type 2, and it's where you drop a complex. Okay. You okay with that, everyone? Not specifically, Bindu, no, because we actually have more than 3 there, then we have 3 there, then we have 2, okay? But it is an AV block, right? Yeah. The thing is with a lot of these rhythms, it's the debate is about the definition and not about the patient, and it's actually the patient we're interested in, all right? Yeah. Okay. One last one. What is the approximate atrial P wave rate there? This is lead 2. It's a tricky one because there's some buried P waves, so I'll give you a hint. Yeah, so you keep it going up a bit. 60, it's not quite there yet. There's some buried ones. Okay, so P wave there, 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 there. One's buried, one there, one there, one there, one there. Okay, so if we count all those buried ones, it's about 100. So that's a real trick, isn't it? So they're all buried, but you can see that the P wave's going along quite regularly. And then we've got the very wide QRSs, which are going regularly too. So they're completely going in opposite ways with each other. Now the ventricular rate's a bit easier to see, isn't it? So what's that? So that's about 60. Okay, so is the PR interval constant? So that's the interval between the P wave and the QRS. No, it's not. Good. So what do you think this ECG abnormality is? What is the rhythm strip? Yeah, it is an AV block of some sort, but it's more complete heart block, isn't it? And the difference between AV block or first degree, where first degree you have a very long gap between the P wave and the QRS, and this does have that, but it also has the fact that we have the ventricles doing their own thing and the atria doing their own thing. So in a sense, we've got complete heart block, all right? So we've got the heart's not really doing very much, and people who have complete heart block have a slow rate. and often it drops down to 40 and they become compromised. Okay, now just a little one for you to think about, true or false. Complete heart block may occur with underlying atrial fibrillation. What do you think? Yes, it can. You can have the atrial fibrillation going along at its own thing, and you can have the ventricles going along doing their own thing, but the atria are actually fibrillating. Yeah, and that in fact you would get a very slow ventricular rate. It could be quite dangerous. Good. All right. I'll just quickly go through these as time's moving on. Name 3 factors that can potentiate digoxin toxicity. True or false? Let's have a look. Ventricular premature beats are frequent manifestations of dig toxicity. That is true. Atrial fibrillation with a rapid ventricular response is a common manifestation of dig toxicity. That's a false. A therapeutic dig level indicates that dig toxicity is not present. And in fact, that is false. Okay, so even if your dig levels are normal, you can still get toxicity in a person. It depends on their individual response, all right? Yeah. Is cardioversion hazardous in the presence of dig toxicity? And can it lead to ventricular fibrillation? Well, that's a very loaded question. In fact, that's true. Okay. All right, did everyone get that? Okay. Why? Okay. Now, watch. Dig toxicity actually slows down conduction, all right? And what it does is also makes the surrounding tissues quite excitable. So the conduction doesn't rely just on those cells which are part of the conduction system. They become excited by other cells. Okay, so that's why if you do cardioversion in the presence of dig toxicity, you can actually set up the ventricles fibrillating. All right? Okay, yeah, no worries. Now I'm going to move on because time's running out. And we have here a monitor. And what I want to talk to you about quickly, and this is what frames a lot of critical illness, is the inflammatory response. Very strange sort of thing to talk about with heart rates and things like that. But in fact, what you'll find is that people who have critical illness have an inflammatory response which has gone haywire. Now, normally you and I rely on an intact inflammatory response to heal. For example, if we cut our hand and it becomes red and swollen and sore, not infected, but just the normal process of healing, and it brings the blood flow to the surface and the platelets to stop the clotting and all those sort of things that inflammation does, then you'll find that your wound will heal well and the skin will become intact. But in fact, with critical illness, what we find is that that inflammatory response, for whatever reason, and there's a lot of things which trigger inflammation, and you may have heard of systemic inflammatory response. What we get is that our heart becomes inflamed and it has some particular mediators from the blood which are part of the white blood cell system, which suppress the cardiac output and make it difficult to conduct. So someone who has an inflammatory response that's a little bit out of the normal response and normal homeostasis will get cardiac rhythms. And one they tend to get most of all is atrial fibrillation. So I'll just go to the next. Here we have a lead 2, which we have atrial fibrillation, and you can see the P waves. This is why atrial fibrillation and other atrial arrhythmias are the most common ones in the ICU. It's because of the inflammatory response that is out of normal in these people. So here we have atrial fibrillation, and we can see we've got 1, 2, 3, 4, 5, 6, 7. I'm going to have a heart rate of about 80, 85, 90, but we have an underlying atrial fibrillation, and that's why we tend to start them on amiodarone if it's dangerous or if it's compromising in some way. And this patient, it might not be. You can see what it looks like on the ECG. And then again, you can see that this patient actually has he's got some hypertrophy because his QRSs in the V leads are very long. Yep, so there probably has, when you have hypertrophy, you usually have an inflammatory state in the heart anyway. Okay, so just keep that in mind, and when you have the next patient with AF that you see, just think about the inflammatory mediators. You might want to see what their C-reactive protein is, because that's one of the things that measures your inflammatory response, or what their white blood cells are. Okay, their temperature. Okay, now you can have all those things elevated without being an infection, and sometimes you have. Okay, so I'll leave you with that thought, and I'll stop recording.